everybody. It's a great pleasure to be here today on this session. I have with me Professor Dirk Arnold from Hamburg, Germany, and we are here to discuss with you some of the abstracts that were presented at the recent ESMO 2023 meeting in Madrid. My name is Zorana Maravic, and I'm the CEO of Digestive Cancers Europe, the European umbrella organization supporting digestive cancer patients. Dirk, welcome.
Thank you, Zorana, and dear friends, patients, colleagues, whoever. I do have the pleasure next to discussing with Zorana, which we will do in the final end, first present some data of innovations in colon cancers. And after having shown my disclosures, and I can guarantee you that this is an unbiased talk, we go now to two important abstracts. And they are about metastatic colorectal cancer, but also clearly about the new therapeutic principles. When we look to the metastatic disease, of course, the characteristics and the treatment goals, I would like to cure the few patients which we can cure despite that they have metastatic disease. We would like to prolong overall survival, but clearly also to maintain quality of life, turning this into a chronic disease. And therapeutic principles are clearly, as you do know, chemotherapy and monoclonal antibodies, immunotherapy, and a super targeted therapy. Super targeted, allow me the phrasing, but we will come to super targeted in a minute, but first start with immunotherapy. Because we have learned that molecular makeup of patients, molecular imaging of patients, molecular characterization is really important. I would like to revisit with you two important subgroups of patients. The first is them which are good candidates for immunotherapy. We'll say the MSI high patients in the metastatic stage, 5 to 7%. And then we go to the RAS mutated patients with colon cancer, which are an entity which is so difficult to treat. But starting with immunotherapy first. And immunotherapy is here by molecular definition, the treatment of choice for microsatellite unstable, or in other words, mismatch repair deficient colon cancers. And here we have been learning that chemotherapy is not as good as immunotherapy. And the Keynote 177 trial has been one of the important trials, the pivotal trials over the last years, where we have learned that randomized phase 3 trial can define a new standard. And I would like to report now the follow-up of 5 years, which is now proving whether the standard is really a standard also in the long-term follow-up. To remind you, Keynote 177, 307 patients with metastatic MSI colon cancers underwent randomization to receive standard chemotherapy plus minus the best monoclonal antibody for this situation, bevacizumab or cetuximab. And patients in the experimental arm had treatment with pembrolizumab, we'll say with a PD-1 inhibitor as first line. Patients were not pre-treated before. And the endpoint now, after 5 years, are overall survival, to say whether really there is an overall survival gain by using immunotherapy. We had some of these readouts before, and this is more or less just an update. The primary endpoint has been, one of these co-primary endpoints, has been progression-free survival. And we can see from these curves that about 50% of patients were not progressing after 3 years to 5 years. And we can see that this was clearly better than patients which had treated with chemotherapy. The specific benefit has been seen in patients which are also responding to treatment, because if they do show an objective response with immunotherapy, this response lasts for a long time. But I would like to come back to the progression-free survival, because progression-free survival means that these patients with this green curve, with a good control after 3 to 5 years, they clearly benefit from this treatment. But patients with chemotherapy, which were progressing, had the chance after progression to also get treatment with pembrolizumab. So therefore, the question is, did this impact on the overall prognosis? And the question is, and the answer is, these are the survival curves. We can see that starting the treatment with pembrolizumab is still favoring the outcome of pembrolizumab versus starting with chemotherapy, despite the fact that more than 60% of patients had a crossover. We'll say patients which started with chemotherapy had, by moment of progression, then access to immunotherapy when they were progressing. 62 patients were following this route. And as you can see here, this doesn't outweigh the benefit the upfront treatment with pembrolizumab had. So therefore, the beginning of these patients with immunotherapy is standard of care. We should not consider to start them first with chemotherapy and immunotherapy later. We should start with immunotherapy first. But the key question here is also, will pembrolizumab remain as the standard of care? We are awaiting more data from randomized trials with also immunocombinations in the next years and the year over next year. So therefore, starting with immunotherapy nowadays means starting with a checkpoint inhibitor single agent, but in the near future, we will see whether this will be replaced by combinations. Now I'd like to come to the second abstract, which was even scientifically more sensational, so to say. And this was presented by Filippo Pietrantonio, a friend from Italy. And he, in this late-breaking abstract, was looking on patients with a specific RAS mutation. And to revisit this, RAS mutated colon cancers, this accounts for about 50% of all mutations and all 50% of all colon metastatic colorectal cancer patients. As you do know, these patients cannot be treated with an anti-EGF receptor antibody. They cannot be treated with an anti-HER2 compound, even if this would be available. So therefore, here we say the RAS mutation is driving the disease, and we have nothing specifically against. So we treat this patient with chemotherapy plus minus, for example, bevacizumab. And now we have first drugs which are developed for these specific mutations. And the story starts with a specific mutation which is called the KRAS G12C mutation. And the phase 3 CodeBreak 300 trial was looking on the efficacy of a specific inhibitor called sotorasib, excuse the typo here, sotorasib with an O, plus panitumumab in chemorefractory metastatic colorectal cancer with this specific mutation. And there is a good rationale to combine the specific inhibitor with an anti-EGF receptor antibody, because we have learned that if we inhibit the specific mutation, then we make the patients, biologically spoken, again to wild-type patients, and wild-type patients can be nicely treated with an anti-EGF receptor inhibitor. And we have seen that this effect is working in colon cancers in these G12C KRAS mutations with the specific inhibitors in combinations with anti-EGFR for various compounds. It's not only sotorasib, it's also other drug called adagrasib, garsorasib, and there's also a further drug which is not mentioned here. So it's 3, 4, or 5 of these specific inhibitors. But in this curve, we have only seen that we induce responses for a certain time. But yeah, how much this is lasting and how much this is really contributing to patients' long-term control is unclear. We have learned that treatment with a specific inhibitor leads to newer mutations. Rodrigo Dienstmann has nicely shown us in the analysis of patients which were treated with adagrasib and cetuximab that acquired resistance is a problem. We have seen that further mutations occur under the pressure of this specific treatment. And the key question is, how long can we really control this disease? This was CodeBreak 300, and this included 160 patients with this specific mutation. And you can see 3 treatment arms. 2 of them were, let's say, containing sotorasib plus panitumumab, sotorasib in 2 different dose levels, whereas the third arm was a kind of standard of care late-line treatment. So either tifluridine, tipiracil, or also called TAS-102, or regorafenib. Endpoint was here not response, it was here progression-free survival. So how long can we control this disease? Well, the effectiveness is already shown here in this table. You can already see that progression-free survival is favoring some of these sotorasib arm Also, objective response is favoring this. And to more graphically show this, these are the PFS curves, the progression-free survival curve. You can see that the green curve, which is sotorasib at 960 milligram plus panitumumab, is way better than the standard of care. And the low dose sotorasib is somewhere in between, but also better than standard of care. So we can say that progression-free survival is more than doubled when patients are treated with sotorasib plus panitumumab compared to standard of care. And also more patients had any tumor shrinkage from baseline compared to the others. And clearly also the low dose sotorasib is better than others, but the winner is, so to say, the normal dose, 960 milligrams sotorasib plus panitumumab. Of course, new treatments have new toxicities or have adverse events we have to balance. And with sotorasib and panitumumab, of course, we did see rash, skin toxicity, as well as hypomagnesemia, we'll say, disorders in the electrolytes of patients, and also some diarrhea. However, also the standard of care chemotherapy or treatment with regorafenib had, as we do know, toxicity. So we have to balance them between. So in the final conclusion, this is the first phase 3 trial of these super specific inhibitors combined with an anti-EGF receptor antibody. The primary endpoint was clearly met. Both doses showed better progression-free survival than standard of care. However, the high dose or normal dose sotorasib showed really the best outcome. And what is the clinical consequence? Of course, if I would see a patient with a G12C inhibitor mutation being chemorefractory today, I would love to treat this patient. So hopefully we have this drug very soon in our hands to give, let's say, this to our patients. And we will clearly see what further trials in earlier stages, first line combinations, etc., for these specific inhibitors will teach us.
Thank you, Dirk, for presenting these two presentations. I think they're both very interesting, but also the second one that shows some promising data for the population with metastatic colorectal cancer with KRAS G12C mutation that is currently, I think it has very unmet needs. So this is really promising. I think it also, both presentations highlight one thing, which is characterization of tumor, how important it is for the tumor to be characterized. And I wanted to just to highlight, you know, in your practice, when are patients being tested, how you discuss this with them? Do they understand that what the name and the surname of their tumor is, like these molecular characteristics, how this affects their treatment?
Well, I think the patients are learning, and I think also thanks to your great activities or all patient advocates activities to teach them and also the public, that patients are aware of that the molecular characteristics or the biological characteristics of their disease has to be present when we do make decisions. And as we have seen here, it's increasingly getting important. The more targets we have, the better we can then also specifically treat patients, the more important this is. So I think they understand. I think they ask for. Otherwise, if they don't ask for, despite that, we have to do this and have to teach patients and have to explain this to patients and relatives. And I do think that we have such a good understanding of basic biology or basic medicine. Many have heard about molecular and biological characteristics that it's now easier to explain than it has been 10 years before.
Definitely. And just, you know, for everybody's awareness, how long does it take usually in your clinic, you know, for the results to come?
Well, these standard tests, BRAF and RAS and MSI, should be present within 1 to 2 weeks maximally. In fact, MSI, which is the easiest test, is at our institute available a day after the sending of the tumor. The other molecular markers need 5 days, a week or so. But I think in most institutes, it's 2 about 2, maybe 3 weeks maximally, but within 2 weeks, I think it should be available.
So this is nothing for patients to worry. No treatment will be delayed. I think this is something, a key message that they have to take home, which is, this just, it doesn't delay the treatment, but it gives them proper treatment, personalized treatment, which is what we are aiming for.
Completely agree, Zorana. And I think it's always, I tell my patients, better to treat right than to treat fast. Fast and right would be ideal, but let's say rather wait, rather think, rather have all information handy. And colorectal cancer is not the disease which has to be immediately treated the day after. There are other diseases like lymphoma or like small cell lung cancer where we cannot wait. But in colon cancer, fortunately, the biology allows us to wait 2 weeks without any major problem. And at least in the utmost patients, and then have the best treatment when we have the information in our hands.
Thank you. And I wanted to ask you the following question based on one of the slides that you presented, that obviously the tumor changes. Does the retesting needs to happen at a certain point?
Yeah, it has to. That's a very good question. That's really end stage management or end stage excellence in management, but we do know that under pressure of a specific treatment, that's what I try to show, other mutations do occur. So therefore we have to retest. And very hopefully we can do the retesting on the blood, we'll say on the DNA of patients, which is circulating in the blood. And we do not, hopefully not have necessarily to re-biopsy. Nowadays, in some situations, we may have to re-biopsy, but I'm pretty sure that within the next 2 years, we have the standard of care that the retesting can be done by a blood test on the basis of ctDNA, we'll say, of the circulating DNA in the blood.
Thank you, Dirk. I think I have asked all the questions that patients might have in their mind. Thank you for being with me today. It was a great pleasure and privilege to be on this session. And I want to thank also our audience for staying with us.
Thank you.